Okay, so the case management and homeotherapeutics, emerging and re-emerging diseases. I think this is section 5 among this. So these are the topics we have to learn. We have to see the difference, what is emerging and re-emerging diseases. What are the differences between them? There's nothing much actually, and how to deal with this. And then some examples of re-emerging diseases and also examples of emerging diseases. One second. Not here. Which department you got told?
Is it Lincoln?
Yeah, Lincoln.
Lincoln. Unit? Examination unit?
Examination unit is in the top floor. It's in
Oh,
the
that's the floor.
uh,
Over here.
it's either on the
Second floor or
yeah,
third floor?
or the third floor. I'm no over to here is business department.
Second floor.
It is
This
in
is
the
of Lincoln?
it is in yeah. This is of Lincoln.
Lincoln. But
It is on the
examination
top.
unit is not here.
No, no.
Second floor. Oh, on the
Second or
second floor.
third, I don't exactly remember, but just top, top of this. You don't have to go to other side, just on the side. Sorry, someone came here, that's why. So we have some examples of re-emerging diseases and emerging diseases. So just need to go through it. And from the examples itself, you know most of these things. So we just go through that. So what we'll see, there are certain new terms like emerging diseases. So, and we also have re-emerging diseases. Then we have deliberately emerging diseases and accidentally emerging diseases. So from the casual English itself, we can understand what is the meaning or the difference between emerging and re-emerging. Emerging means something that should be coming up newly. That's when we use the term emerge. And re-emerging, which means it was emerging or something, but now it is happening again. So somewhere it was emerging and then it was reduced, and now due to some or the other reason it is coming up. So that is the basic difference between emerging and re-emerging diseases. So emerging diseases are something that is newly coming up, and re-emerging, it was present there due to some treatment or something, it was able to be reduced, but the changing lifestyle or some other factors, environmental factors, helped in the reappearance of that disease. That is the re-emerging disease. So newly emerging means the diseases that were not previously described in humans. It suddenly appeared, such as HIV and AIDS. So HIV and AIDS, though we say it's an emerging disease, like it appeared first in the year 1980s, 81, I think, to be exact. But before to that, it was unknown. And since then, it is spreading. It is, we can never say that it has reduced a lot and now it is becoming re-emerging. Nothing like that. It is actually reducing in some part of the country, some part of the world, but in other parts, it is still an ongoing, it is not being reduced that much. So HIV and AIDS or AIDS is considered as an emerging infectious disease. And we have the re-emerging infectious disease. These are the diseases which have spread to new places or which was controlled by previous treatment but is not working now. And the diseases will be dengue, malaria, tuberculosis, etc. You might be knowing a lot of tuberculosis cases are actually antibiotic resistant now. They have, I mean, allopathic people, they have antibiotics against this tuberculosis, the mycobacterium tuberculosis, and they are actually this one. Resistant type of tuberculosis. So these diseases initially they were reducing, but now coming up, or they are spreading to new places. And deliberately emerging means the diseases created by humans for bioterrorism. Our SARS, avian influenza, it all came under the bioterrorism in the early 2000s. Then accidentally emerging infectious disease which are created or spread unintentionally by humans, such as vaccine-derived poliovirus. So to control the poliovirus, when you learn polio, maybe you have learned that there are vaccines, and one of the vaccine variety, it can induce actually polio. So it was accidentally emerging, but when the scientists discovered that this vaccine could induce, they have been trying to reduce its usage. They are still not able to control it properly, no control to withdraw it properly from the market, because this particular strain of organism from which this polio vaccine is taken, it is actually highly effective also. It is highly effective also to control polio, but still some of variety in that, and in some people it can induce polio also. But when considering the number of the new polio cases induced by this vaccine, comparing to the number of polio they are able to control, the number is very less, which can cause this vaccine derived polio. That is why it is still being utilized, but still, scientists are now aware that this particular strain from which the vaccine is taken can result in inducing polio. Say they are in a uh, pathway to reduce or to stop its control usage by developing new strains, which will be effective against polio but won't be inducing this I mean, vaccine induced polio. So the emerging infectious disease, as I already told, newly discovered infectious agent. These are the diseases which are caused by the newly discovered infectious agent or by a newly identified variant of a non-pathogen. It has emerged and whose incidence in human has increased during the last 2 decades and is threatening to increase in the near future. This term also refers to those diseases which was formerly confined to one geographical area and has now spread to other areas. So some of the examples are Ebola virus, HIV or AIDS, hepatitis C. Hepatitis C first identified in 1989, now known to be the most common cause of post-transfusion hepatitis worldwide. And this one is the most important variety, which is resulting in chronic hepatitis or even cancer. Then influenza A virus H5N1, well-known pathogen in birds, which is the avian influenza, and it was first isolated from humans in 1997. Then Legionella pneumophila. In 1976, this resulted in the first outbreak of the disease, Legionnaire disease. And usually, this was first outbreak in 1976 in USA, and it was due to poorly maintained air conditioning systems. Then we have E. coli, detected in 1982, and it results in hemolytic uremic syndrome. Then Borrelia burgdorferi, detected in 1982, and it's an important cause for Lyme disease. And this disease is something that is very commonly seen in the USA. Then there is another disease which is called as Creutzfeldt-Jakob disease, which is also considered as an emerging disease. It was first described in 1996. And this one is same as that which causes bovine spongiform encephalitis, or what we call as mad cow disease. So this is a disease which emerged in the 1980s and affected thousands of cattle in the UK and Europe. Then other diseases are SARS, hantavirus, pandemic influenza, Nipah, West Nile virus, and Zika virus. And from here we have to learn only SARS, influenza, Nipah virus, and also HIV. Now, regarding the re-emerging infectious diseases, the diseases which was previously, these diseases existed in the past and then it was controlled, but once again it has risen to be a significant health problem. One of the reasons that they say is a decreased compliance with the vaccination policy. One example could also be diphtheria. In diphtheria, initially there was actually vaccination going on. So the cases of diphtheria was very, very less or reducing very much. Now, if you remember our literature in organon or materia medica, you always see something called as post-diphtheritic paralysis. Many of the conditions you can say post diphtheritic paralysis. So diphtheria was very common in that time, 18th century or something, But when after the vaccine was introduced, the cases of diphtheria started reducing. But when the people who were anti or against vaccine, they came up as a group, they started declining to use these vaccines. And as a result, the cases of diphtheria is now re-emerging. So re-emerging are those diseases which were existing at one time, and then because of the treatment that was introduced, the cases reduced as much. But now, due to one or the other reason, these diseases are again coming up. The use of deadly pathogens such as smallpox or anthrax as, such, as agents of bioterrorism is an increasingly acknowledged threat. This re-emergence can happen when there is a breakdown in public health measures, when new strains of known bacteria or virus is appearing, and whenever there is a change in human behavior, like overuse of antibiotics. So the organism that develop will be soon resistant towards the existing antibiotics. So then they have to find out a new medicine which will be able to control this bacteria or the microorganism that is causing the disease. So these are the examples which we already discussed. Now we'll start with the examples of the emerging diseases and starting with pandemic influenza. So influenza virus which causes the pandemic influenza, it belongs to the orthomyxo group, and Nipah virus which is the other one we have to study, it belongs to the paramyxo group. So when we see the classification, there is a group of virus which is called as myxovirus, and it is being classified into two, orthomyxovirus and paramyxovirus. And it is in this orthomyxovirus, influenza virus is belonging to, and it is in the paramyxovirus. They are given a lot of examples, parainfluenza, mumps, measles, etc. But it is in this group, Nipah virus is also included, and we are more interested in that. And mixo, which means it has great affinity to mucin, which means these bacteria, sorry, these viruses will be mostly affecting the structure systems in which there is a mucin layer. So the respiratory, GIT, mostly, these are the system in which these viruses will be affecting. So starting with the influenza virus, which belongs to the category of orthomyxoviridae, it causes influenza, which is very more serious, and this has caused several epidemics and pandemics of respiratory diseases. It is a major cause of morbidity and mortality. We have swine flu, bird flu or the avian flu, and also human flu type. Then regarding the influenza virus morphology, I don't think you have to study this in detail. I just kept it over there. So it is a single-stranded RNA virus. It is having a helical nucleocapsid and it is surrounded by the envelope. And in the envelope, we have proteins, especially the HA and NA. HA will be the heme agglutinin. We can see as a spikes. So the triangular shaped, that is the HA variety, the envelope protein, and the mushroom shaped, which is green in color, that is the NA, neuraminidase variety. And this one, it is ideal, or it is good that if you remember the names, because for the diagnosis of the disease, we for especially for the antigen tracing, we check whether there is the presence of these proteins HA and NA. And even the influenza viruses have been classified according to the HA and NA or hemagglutinin and neuraminidase variety that is present. So only for that you have to just remember HA and NA, otherwise it's not important, the morphology. Then regarding the pathogenesis, we have reservoir of this influenza virus. It can be a human case, subclinical cases in which the symptoms are not there, can be animals and also birds. And how it is transmitted? Mainly via human or avian. So human, it will be person to person via contacts or aerosols or the droplet infection, or via the fomites, the beddings, clothings and other things that is used by the patient. And if the other person is closely coming in contact with those fomites, then the person can develop. The avian, which is from birds to human, and that usually happens via fecal-oral route or by direct contact. Direct contact in those people who are dealing with birds. There will be people who are who have the habit of dealing what is that domestication of the birds, so in that direct contact, or also it can happen in veterinarians and maybe lab people who are studying with the birds, so a direct contact with them, or even a fecal oral route. And fecal oral route, mostly how it happens means the bird excreta. The bird excreta, when it is getting dried, there may be some um, aerosols that might have formed around that dried excreta. So when people are going to clean over that area, like in an area where so many birds are living, and it is not kept clean or something, and they have that dried excreta. So if any of the birds are infected, this virus will be excreted via their stool or their droppings. So when these droppings, if it is getting dried, and a being is going to clean that area without a proper mask or something, even that inhalation, the dried excreta will be converted into aerosol, and in that aerosol, this viral particle may be present. So person is going to clean that area without a proper protection, and even that inhalation can cause the disease appearance in that human being. And from then, from the human being, it can be person to person transmission. Now, how the virus spreads, like after the entry of the virus into the human being, it can spread to the respiratory tract. But even if it spread to the respiratory tract, in case of influenza, it will be only mostly in the upper respiratory tract. Very rarely only it will move towards the lower respiratory tract. And then it can spill over the bloodstream also. And if it is spreading to bloodstream, then many different organs can be affected. So it can involve extrapulmonary sites, or the sites which are not just confined to the lungs, but other systems, organs can also be involved. The most important feature in case of influenza will be a local damage, the local upper respiratory tract damage. There will be edema, mononuclear cell infiltration, which shows pathologically the signs of acute inflammation. Then there can be cytokine influx, and that is the main reason for local symptoms. And now, when I say cytokine influx, if you remember, we have to deal coronavirus in coming up slides. But if you remember the coronavirus or the COVID, at that time, we used to read or hear the news about something which is called as cytokine storm. So we used to read the articles in the newspaper, not even in the scientific journals, in the newspaper or the any media. We used to get the word cytokine storm. So this COVID was resulting in cytokine storm. So the similar one in COVID, it was the extreme one, the cytokine storm, as the term indicates, storm. It was a very violent one. But in the influenza virus also, the cytokine influx was happening. And cytokine influx, you have studied acute inflammation. And in acute inflammation, one of the features will be the release of certain cytokines. And these cytokines can result, actually, it is produced a part of the immunity to kill that external pathogen which has resulted in that acute inflammation. But acute inflammation, if it is not, we are controlling it, or the body is not able to control it, if it is going excessively, it can result in local system damage, or that local area damage, which can result in multi organ failure. So that was happening into the extreme in case of coronavirus. But this cytokine influx is also happening in case of, this one is also happening in case of influenza virus. And this is due to the excessive acute inflammation that is happening. Then there will be cellular destruction, desquamation of the superficial mucosa of the respiratory tract due to the cytokine influx also. And because there is cellular destruction, the desquamation of the superficial mucosa, it can predispose the secondary bacterial infection. If you remember the class from your immunology, you might be remembering we have the immunoglobulins IgG, A, M, E, and D variety. Out of it, IgA variety is actually all these immunoglobulins are seen in blood, but IgA variety can also be seen on the superficial mucosal layer. So whatever the structures, it is covered with a mucosal layer. A thin layer of painting, we can say, of IgA can be seen. So when you learned innate immunity, in innate immunity, if you remember now, you might have learned that there is a painting or a layer of paint, we could say like that, of IgA over to the mucosal structures. So, be it the mouth or the nasal tract or the genitourinary tract, wherever the mucosal layer is there, a superficial paint of IgA will be seen. And the use of this IgA will be to kill the organisms or the pathogens which enter. So if that superficial layer is desquamed, which means IgA is not there can be predisposition to secondary bacterial invasion. Or more and more invasion can happen because there is no immunoglobulin A to protect. The clinical manifestation, we call it as influenza or flu syndrome, acute respiratory tract infection, where the incubation period is very short, like 18 to 72 hours. Most sometimes it will be asymptomatic, and if at all symptoms are there, it will be minor upper respiratory symptoms, chill, headache, malaise, sore throat, rhinitis, dry cough, etc. And it will be followed by high grade fever, myalgia, anorexia. It's a self-limiting condition, means even if we treat or not treat, usually most of the condition it won't go into that much complication. It will be reducing by itself, and most common it happens during winter. It's the most common seasonal flu. You know that the strain varies from season to season and also from place to place. In Pondicherry, which is a place in India, in 2018, the variety that came up, which resulted in the influenza, was H3N2. This strain variation is a particular feature of influenza virus actually. So, what are the complications? If at all it is appearing, it will be pneumonia, and that too because of the secondary bacterial invasion. Worsening of the COPD, patients who already have some chronic obstructive pulmonary disease, that is chronic bronchitis and emphysema mainly, they will be getting worsened if the influenza comes up. Then there is Guillain-Barré syndrome. You might be remembering that. It will be like a person who was healthy actually, but then suddenly he had a fever, and within a week or something, he goes into a paralytic stage. So that is actually Guillain-Barré syndrome, and it usually happens post-influenza, after two influenza. And what happens here is a person's own immune system, the own immune cells, will harm the body's nerves, so that there will be muscle weakness and leading to even paralysis. Another important complication will be the Ray's syndrome. And Ray's syndrome, usually this is seen as a, or you might have studied this as a complication of chickenpox, or that is caused by varicella zoster. But Ray's syndrome can also be appearing as a complication followed to influenza B virus infection. So there are two factors or two things that is coming under Ray's syndrome. One is involvement of the liver, there is fatty degeneration, and also involvement of the brain, the encephalitis or acute encephalopathy. So there will be symptoms in two different organs. That's why, or that's how we call this term syndrome. Whenever you learn a disease with syndrome, which means two organs or two or more organs will be involved in it, and they will be producing symptoms, concern symptoms according to the site that is affected. And when they come together, clap together, we call it as a syndrome. So Ray's syndrome, it actually happens after two influenza B infection or varicella zoster or chickenpox infection, mostly in children and adolescents. And the two features that we see here is the involvement of liver, where there is fatty degeneration. So related liver symptoms will be the, and also acute encephalopathy. So encephalitis related symptoms also will be there. So these are the complications possible in case of influenza. And the name nomenclature has been given, and that is based on the different proteins that is present in the virus. So it is named as influenza virus A, B, C, and D. Then based on that HA and NA antigens, I told you the hemagglutinin and neuraminidase, it is being classified into H1 to H18 based on the HA variety, and NA variety N1 to N11, but you don't have to study this. The standard nomenclature is the influenza type, host if it is non-human, geographic origin, strain number, year of isolation, HANA subtype. So if it is a human strain, the influenza type, that is influenza A, and we don't have to give the host because it is required only if it is non-human. So the geographic origin, it was in Hong Kong. The strain number 03, year of isolation 1968, and HNA variety H3N2. Because we have given here the number, H can be H1 to H18, and NA variety, it will be named as N1 to N11. So the H3N2 variety, that's one type. Then a non-human strain, the example, you can see influenza A. And because it is a non-human, we have to give the host, that's the swine. Uh, I don't know whether it is Iowa or Iowa. I wanted to check it, but I forgot. I think this is a place in the USA, but I don't know how it is pronounced. So Iowa, maybe Iowa, I think. You know how it is pronounced?
Iowa.
Iowa. Okay. So this that's a place in the US itself, na?
Yes,
Yeah.
in America.
Okay. Okay. So Iowa, and then the strain number, which is 15, 1930 was the year in which it was isolated, and the H1 and the N1. So this is how the name is done, but I just told that for the exam purpose and all, it's not that important. But this portion is important. The antigenic variation or the mutation that is happening in case of influenza virus, and pathologically when we see this variation is very very important for your knowledge also, and also for the exam thing. So we have two type of antigenic variation or mutation that is happening in influenza virus: antigenic drift and antigenic shift. So the difference is only in the second term that is used. So a question can ask in short essay question, or the or even in the MCQ, what is the what the features coming under antigenic drift and antigenic shift. So in case of drift, there is only minor change. The point mutation is happening. So point mutation means only one of the point, the um, nitrogen base involved in it, only one will be changing, either insertion or deletion or an replacement, that will be happening, but at one point. So it is the point mutation that is happening, especially in the HA or NA gene, and that results in minor periodic epidemics. So there will be some small outbreaks, some epidemics, but which is minor in nature. It produces milder diseases, and it occurs more frequently. Like every 2 to 3 years, the influenza virus will be undergoing a antigenic drift. And whenever it goes antigenic drift, it produces a point mutation. And point mutation is happening in the HA or the NA antigen. And that results in smaller outbreaks or epidemics. So every 2 3 years, we can see some variation of the influenza virus that is happening, which results in a seasonal epidemic. And in case of antigenic shift, here major variations is happening in the sequence of a HA or NA. Mostly it is not a this point mutation that is happening, but a recombination. a recombination of the human, animal, or the avian strain that is happening, which is a major change, and that results in the pandemics. That results in pandemic and also major epidemics. So the minor periodic epidemics in every 2 to 3 years, which results in milder disease, is produced due to a antigenic drift. But in antigenic shift, it is the genetic recombination that is happening, and that results in pandemics and major epidemics. The example is H1N1 pandemic of 2009. This is most serious, and this antigenic shift occurs less frequently every 10 to 20 years. So all these points, the type of the epidemics, the frequency in which it is happening, and also the type of the disease they cause. You need to remember the antigenic drift and an antigenic shift. It is a very important feature in case of influenza virus. So this is the history of influenza A and B virus. When you get the PPT, you can go through that. Then avian virus, the H5N1, the transmission from birds. It was first reported in Hong Kong, and it is remaining as an endemic for the past 15 years. There is less morbidity, but the problem is more mortality. So the people who are getting affected, the morbidity is very less, but more and more people are getting died. Then clinical features, incubation period is 2 to 4 days. There can be typical flu-like illness, and lower respiratory symptoms are also common with cough, shortness of breath. Complications like pneumonia and ARDS is also very common. There can be extrapulmonary manifestations where we see diarrhea and also CNS involvement. Diagnosis, we can do real-time RT-PCR from the pharyngeal or nasal swab. That one avian strain, I just put it in this one because I was already dealing with influenza, so I thought I will just put it for your general information. Otherwise, influenza, we don't have to do this avian specially. It's just a part of that influenza virus, the avian influenza I included. Then H1N1, which is the swine flu in India, which happened, and it happened from direct contacts with pigs. That's why the term swine flu. It was uncomplicated, mostly with mild upper respiratory tract illness. And in high risk group, it was resulting in complicated or severe influenza. There was bacterial pneumonia, CNS involvement, multi organ failure, or sometimes even dehydration. And lab diagnosis, we could use RT-PCR, the reverse transcriptase PCR, or real-time RT-PCR and antibody detection. So this is the difference of the pathology caused by H1N1 and H5N1. In H1N1, mostly you see the infection is seen in the upper respiratory tract, and this is easily spread but rarely fatal because the infection mostly get confined to the upper respiratory tract. While in case of H5 and N1, you can see it is the lower respiratory tract or the lungs that are involved more. It spreads so slowly, but it is often very fatal. Then lab diagnosis, we already discussed. In total, it will be, we can do the specimen collection and view it under the microscope. So for that, we can see take the nasopharyngeal swab, nasal aspirate, or even the throat swab. Then swabs are immediately put inside the viral transport media kept at 4 degrees Celsius during transport and thereafter at minus 70 degrees Celsius. We can do the direct immunofluorescence test where we can see the viral antigens, and those viral antigens will be the HA and the NA variety. We can use the RT-PCR to detect the influenza virus or the real-time RT-PCR. We can do the antibody detection by heme agglutination inhibition test. There is neutralization test also, which is actually very specific to diagnose influenza, but this is very difficult to perform and time consuming and hence not that commonly used. We can also do the ELISA, which is very sensitive and it detects the antibody against HA and O NA antigens. We go to the next variety, the Paramyxoviridae. And the virus we need from this group, we have actually parainfluenza, measles, mumps, RSV. I don't know why I put RCV. It is actually RSV. But the thing which we need over here is actually the Nipah virus, and that causes the respiratory infection in infants and children. So in case of Paramyxoviridae, its genome is also single-stranded RNA. We have a nucleocapsid which is helical. Doesn't matter that much. Then yeah, its structure and all matters in microbiology mostly, but not in case management. So we have the peplomers or the glycoproteins, which is the heme agglutinin and neuraminidase. We also have fusion protein, which had the virus to fuse to the host cell. So in case of Nipah virus, I don't know whether you know about Nipah virus. The most recent one which happened was um, in Kerala, in my own state, in the year 2019, no, 2018. Uh, there was actually 18 cases that was confirmed with Nipah infection, and out of that 17 people passed away. So just imagine the case severity or the case attack rate, whatever we studied in the epidemiology. It was very, very, very serious. 18 people were diagnosed that were confirmed Nipah virus infection, and out of that 18, 17 passed away. Uh, but government was very successful to control that infection. Though we lost 18 people, they were very able to control that infection going beyond more people. So what happened there was it actually happened in two districts of Kerala, the two northern districts. So one of the person, the when they trace the history, like using the now we can go for the epidemiology, whatever you learned. So when a outbreak happens, you know the different steps. So you now have to diagnose, and before to that, you have to take the cases and see how that contact tracing or how that got spread. So when they took the case, the first case, the index case, they understood that this person who was first infected with Nipah virus, luckily the first person, the primary case itself became the index case. Primary case means the person who, in whom the disease is happening, and index case the person who is coming to the this one hospital. So sometimes it may not be the same, but in this case, what happened in Kerala, it was actually the same one, same person. It was a very young person, maybe in his 20s, late 20s or early 20s. It was in 20s anyway. So the case when it was taken, it was seen that this person ate some fruits uh, that was lying on the back his garden area or this compound. There was some fruits, and he ate that fruits. And when it was sent for further investigations, the virological investigation, it was discovered that this fruit was infected by the juices, the digestive juices of a fruit bats actually. So we naturally have a tendency, the fruits which we see in the trees and all, especially in our home area, when that falls down, it may be bitten by birds and all. So what I had seen in my childhood was just cut it off that area. They clean very nicely and then we eat. The same thing that guy also did. He saw some fruits lying on his compound area, which was bitten by the bats. He just cleaned it, cut that area, and had it. But maybe the juice, the digestive juice, was present in the other parts of the fruits also. He got that infection. And from him, his family also got infected, his mother, his brother. Uh, and then this was spread from this family to the neighboring family. So, like that, a small area, it got only transmitted to that small area, the neighborhood area. It didn't get transfer. or it didn't get transmitted to a bigger area like the coronavirus infection. That much didn't happen. That was why we were at least able to reduce the severity or more and more cases being appearing. So the first person, this boy who ate that fruit when he had some symptoms. Initially, there was fever, some allergic rhinitis, etc., of which they didn't give much care. But it was rapidly transmitting. That's how his family also got infected. But it in 2 or 3 days itself, the person started showing the symptoms of encephalitis. So then he was taken to the hospital. But in hospital, very soon, I think maybe 1 day or maximum 1.5, not even 2 days, he survived. He passed away. And when he got passed away, such in a very short span, the family also got actually worried, and even their symptoms were worsening, and they were also admitted. The second case or the third case itself, the doctors felt a doubt, and they sent their secretions for the diagnosis of Nipah virus. They had a doubt whether it is Nipah virus itself, and it was confirmed that the persons were having the Nipah virus infection. And then the team came up, the epidemiologist team, the public health team of Kerala. Then the contact was traced. But because this person hadn't gone too much distance, that the disease was confined in that small area. Then the neighbors were also taken to the hospital. And from these patients, even the hospital workers, they also got infected. And the one person who died was actually a nurse, um, who was working in this hospital. She also passed away while she was taking care of these patients. So that was the Nipah virus, which happened in Kerala in 2019. And this Nipah virus was actually happened in the early 2000s, I think, and that was first time it happened in actually Malaysia, in one of the area in Malaysia itself. People who were dealing with uh, this farming, cattle farming or pig farming, they were dealing with that, and they had this infection. And when it happened in Malaysia, it also happened in Singapore. uh, and nowadays I think what I read in book is it is like every 1 to 2 year, 1 or 2 cases of Nipah comes over here, or very not over here. These people who got the infection, there were many Bangladeshis also who were working in this area when the infection spread. But in Malaysia or Singapore, when the infection happened, there was no much casualties. There were symptoms, but no much casualties. Uh, but after to that, Malaysia and Singapore were able to control the infection. But because there were Bangladeshis who were working in this area, they were traveling back to their country. And now in Bangladesh, this is a every year story or every couple of years story that Nipah cases appears. But what happened in Kerala, that was the first situation which happened in whole of South India. So this is the story of Nipah virus. The natural host is actually the fruit bats. It can actually get transmitted by consuming fruits, which is eaten by the infected bats and birds. Then it can be transmitted also via the pigs, and people who are coming in direct contact with these pigs can get infected. And when one human being is infected, and then there can be human to human transmission with through contact or droplet or the aerosol. This can be transmitted. So the Nipah virus is actually a zoonotic virus belonging to the paramyxo group. Fruit bats or flying foxes are the natural host. Incubation period is 4 to 14 days or as long as 45 days. But that case that appeared in Kerala, the incubation period was 4 to 14 days. I mean, even lesser than that, 3 to 4 days. That was the thing. Because all these deaths, 18 cases and 17 deaths, it happened just in a span of 1 or 2 weeks, not more than that. The transmission, it can happen from animals to human. contaminated food or the fruits I told, or directly between the people. Illnesses can be asymptomatic, acute respiratory illness, but in Kerala, when it happened, it produced the fatal encephalitis, and that resulted in death of this much people. Yeah, this was first recognized in 1999 among the pig farmers in Malaysia. So symptoms, it can be fever, headache, myalgia, vomiting, sore throat, dizziness, drowsiness. But the main reason for that is actually the involvement of the uh, brain involvement, or when there is acute encephalitis producing the neurological signs. A typical pneumonia and severe respiratory problems, including acute respiratory distress. Encephalitis and seizures occur in severe cases, progressing to coma within 24 to 48 hours, and that finally leading to death. Lab diagnosis, we can do real time PCR from throat and nasal swabs, CSF, urine, and blood examination, and antibody detection by ELISA. We go to the third variety, the coronavirus, because another disease which we have to study is the SARS. So this is also SS, or the single-stranded RNA virus. Uh, and actually, when we see the envelope, we can see some structural proteins. And that structural proteins will give it a appearance of a crown-like, uh, and that is why it is called as coronavirus, like a crown when we see it under the microscope. So, giving it appearance of solar corona or the crown-like, and that is why he got the name. It got the name coronavirus. So we have four classification: alpha, beta, gamma, and delta. Human coronaviruses are alpha and beta. But however, we saw when COVID-19 came, the delta was also one of the most important that affected men or human beings. And in India, this was the worst variety, the delta variety, which produced most number of death, especially in the second wave that happened in 2021. Coronaviruses were first identified in the 1960s, and it causes respiratory infections. Mostly it is common cold to even severe diseases. The first one we could say, which produced by the coronaviruses, is the MERS, or Middle East Respiratory Syndrome, which first happened in Saudi Arabia, but it got confined in that Middle East countries only. That is why it is called as MERS, Middle East Respiratory Syndrome. It happened in the year 2012. And then when we have SARS, the Severe Acute Respiratory Syndrome, which was seen from 2002 to 2004. And the recently discovered coronavirus, the COVID-19. Transmission by coughing, sneezing, and personal contact. SARS-CoV can also spread via droplets and rarely spread through the air or the airborne spread. So the SARS-CoV history, it was first recognized in China in 2003 by WHO physician, spread from Asia to various regions of the world. Sources: animal, including monkey, Himalayan palm civets, raccoon dogs, cats, dogs, and rodents. Clinical manifestation, mostly they produce influenza-like symptoms, but also can produce severe lower respiratory tract infection. And after 2 to 10 days of respiratory symptoms can develop into more complications, that is dyspnea and pneumonia. In case of MERS COVID or the coronavirus, it happened, or it was first identified in Saudi Arabia in 2012. Human to human infection happened due to close contact. Major reservoir were camels, and that is why it got confined in the Middle East. Zoonotic virus, it is transmitted between animals and people. Incubation period was 2 to 14 days. And the other symptoms, what we always say in the influenza virus or the SARS, is always the same. It was either asymptomatic and then mild symptomatic, fever, cough, shortness of breath, or pneumonia was very common. And then in severe cases, there was also respiratory failure or kidney failure. It also produced GIT symptoms, including diarrhea. And when we see this kidney failure, we don't see this kidney failure being happened in COVID-19 or even in SARS. As a feature of MERS-CoV. So this is a picture which shows the difference. You can see it later. Now going towards COVID-19, which happened in December 2009, outbreak in Wuhan, China. And this is the different terminology that was given. You might be already knowing that. So it was traced as a novel strain of coronavirus, and then WHO initially gave the name 2019 nCoV, coronavirus, that is CoV, and N will be novel. Later, it was named as SARS-CoV-2 by the International Committee on Taxonomy of Virus. But when it became pandemic, it was later renamed as COVID-19. In the first 3 months itself, nearly 1 million people were infected and 50,000 died. Mild to moderate respiratory illness. It became very severe in those people who were aged or the older people and who were having some other diseases, comorbid conditions like cardiovascular disease, diabetes, chronic respiratory disease, and even cancer. The mode of spread, you know how it spread from person to person through droplets, cough, sneeze, etc. So hence we were asked to follow the respiratory etiquette to maintain the distance, etc. The symptoms, fever, headache, sore throat, cough, mucus, fatigue, lack of appetite, body ache, loss of smell or taste, which was very characteristic, nausea, and also diarrhea. Complications, as usual, pneumonia, septic shock, and death was happening. Cytokine release syndrome or a cytokine storm, which I told you earlier, that was a very important reason. Here, the infection triggered immune system to flood the bloodstream with inflammatory proteins. And this was actually when the virus enters, the immunity or the immune mechanism want to destroy that virus. And because of that, it got highly activated or exaggerated activation. And all the immune cells, especially the neutrophil, dendritic cells, macrophages, those are the first line of defenses. Even the eosinophils, they got highly activated and they release that chemicals, the cytokines. And this can kill tissue and damage organs. So the cytokine release syndrome or the cytokine storm was one of the most important reason why COVID-19 resulted in much rate of mortality. Some people have dangerous blood clots, including in their legs, lungs, and arteries. This we have also heard about it. And the prevention measures using sanitizer, cough or sneeze into inner elbow, or using a mask, cleaning our hands, which is very, we know that. Then lab diagnosis by antigen detection using the ELISA test, electron microscopy to view the enteric coronavirus from the stool. If it is in the GIT, then definitely it will be excreted via stool. So that could be used. But we didn't use this method anyway for our detection when COVID-19 came. Then what we did was actually the RT-PCR from the respiratory secretions and also in stool samples, not that much though. Isolation of human coronaviruses was extremely difficult. We could also do the antibody detection using the ELISA and heme agglutination inhibition test. Rising titer of antibody between acute and convalescent serum can be used to confirm the diagnosis. Now, the last one in case of emerging diseases is HIV and AIDS. Even this we can skip easily because I think in study of patient and diseases also you're studying AIDS. You have already might have learned AIDS. So HIV, it's actually the etiological agents of AIDS or acute immunodeficiency syndrome. The first case was diagnosed in 1981 from Los Angeles in New York. And this was first diagnosed in certain homosexuals, the male homosexuals. Now, I don't know whether you remember or not, when we were discussing about the epidemiological studies, I was saying you the example how AIDS was first discovered, because it was discovered in America itself, actually, as they say, the Los Angeles. So at that time, During this 1981, 82, that I mean, not 80, 81, that time, a lot of patients, not a lot, but some number of patients who were males came with a particular type of pneumonia. And that pneumonia, very soon, the physicians were able to find it is due to pneumocystis carinii pneumonia. So this was a rare type of pneumonia that was seen until then. Uh, Physicians knew the presence of such a pneumonia, but it was not very common. It is usually called as an opportunistic infection. Only when the opportunistic infections are those only when the immunity mechanism of a person is getting lowered. Only then these bacteria or the viruses or any microorganism, the fungi or whatever, they will be getting activated and they will be producing the symptoms. Otherwise, when the person is very healthy, the immune mechanism is so strong, it won't produce any any infection. So only when the situations are favoring, these organisms will be utilizing it and causes the infection. So it was an opportunistic infection. So, physicians in America at that time noticed that many males who are in younger age, like 20s, 30s, they were coming with this particular type of pneumonia. And some also had the Kaposi sarcoma, which is a characteristic type of tumor. So they were able to diagnose this disease, like it is the pneumocystis carinii pneumonia and also the Kaposi sarcoma, but they were not able to understand why this group of people are having these symptoms. So they started studying about the origin of the disease, the characteristic feature. So what we learned from the previous slides, the descriptive epidemiology. They had the case report, the single patient. Then they were having many patients. So there were a case series, and then they were trying to describe. And when they tried to describe the persons, their age, their sex, all the things what we studied, their features, they understood that these people have something in common, that they are male homosexuals. And then when they got the thing that they were male homosexuals, somehow they were able to connect it should be a sexually transmitted disease. And then the investigation was further carried out in that manner, and that is how they discovered the AIDS actually, or the HIV virus. So this was the story in discovering about the AIDS. Uh, so we have the timeline, the HIV AIDS. You can go through it later. Isolation of HIV, we have two types of HIV virus, HIV-1 and HIV-2. HIV-1 was discovered in 1983 from Pasteur Institute in Paris and HIV-2 in 1985. And it was discovered first. It was given the name HTLV3 OLAV. So HTLV3 is human T cell lymphotropic virus type 3 or lymphadenopathy associated virus by an international scientific committee, but later it was renamed as HIV, human immunodeficiency virus. It is believed that initially the HIV was acquired from chimpanzees. Virus belong to the genus Retroviridae and subfamily Lentivirus, which means slow viruses. And you know that it takes years to develop the symptoms. It possesses this HIV virus, it possesses a unique enzyme which is called as reverse transcriptase. And this is very important because we have seen that HIV virus is actually a RNA virus. And this HIV virus, they have a special ability. They will enter into the human body. They will get attached to the human cell. And this RNA of the HIV, using this enzyme reverse transcriptase, they be converted into DNA. And then it will combine with the human cell DNA. And from there on, it starts producing the DNA, but that, or the virion particle, but that DNA or the protein is not of the human cell. Now the DNA that is being produced is by the or of the HIV type. And using this virion particle, they will be coming out of the cell, and then this virion particle will move to the next cell during the same process. So why HIV become this severe is HIV get into the human cell and change that nucleic this protein production process. They will be converting the RNA in the HIV. They will be converting using the enzyme reverse transcriptase to DNA, and then combined with our nuclear mechanism or the DNA, and then starts to produce the DNA particles, which is actually of HIV, not of human being. And then they will carry on this infection to other cells also. So this enzyme, the presence of reverse transcriptase is very important because it is the presence of reverse transcriptase which help to convert the RNA in the HIV to DNA, and then they are having the control of our nuclear mechanism. So HIV morphology, it is RNA virus, and it is an envelope virus. It is having glycoprotein 120 and also GP41. So these structures are very important because they actually help in the uh, adhering to the human cell actually. Capsid is icosahedral in symmetry, and it is actually single-stranded linear diploid RNA, or two identical copies will be present in the genome. Other things I don't want you to remember also. And some enzymes, this HIV virus is having certain enzymes. Out of these enzymes, three are very important. The reverse transcriptase, importance of reverse transcriptase, I told you. It helps in converting the HIV, RNA of the HIV to DNA variety so that they can combine with the human cell. Then integrase to integrate with the human cell. They need one enzyme, that is integrase, and proteases, as the name indicates, to break down various proteins. So these three enzymes are the one which is present in HIV and highly important for their pathogenetic process. And then HIV has got certain genes, antigens, which are very important. So there are 9 genes, out of which 3 are structural gene and 6 are non-structural gene. The three structural genes are ENV or N, GAG, and POL. And 6 non-structural, all these names are there. The non-structural genes you don't have to remember, but it will be ideal if you remember the 3 structural gene, the name of it, and what is their function. So in case of the structural genes, the first one is GAG or the group antigen. You don't have to remember this one, the nucleocapsid protein. No, you don't have to. Just remember that GAG or the group antigen, it gives the shape for the capsid, the icosahedral or that shape. It is given by this GAG genes. Can be asked actually as a MCQ, the gene that is responsible to give shape for the capsid, nuclear capsid of the HIV virus. Like that, MCQ related, this can be important. Then POL, which is actually the polymerase antigen, and this is responsible for the production of the viral enzymes, the viral enzymes that we saw earlier, the reverse transcriptase, protease, and integrase. So these enzymes, especially the reverse transcriptase, that is produced by the gene POL or polymerase. Then we have the third important gene in the HIV, that is ENV or the envelope protein. So envelope, so you understand that it is forming the envelope, and the main help is given. It helps HIV to fuse to the CD4 cells. CD4 cells is a type of T cells, the T lymphocytes, and HIV virus have got a special predilection for the CD4 cells. After combining with the CD4 cells, they results in the destruction of the CD4 cells. So normally, when we take 1 cubic mm of blood, we should be getting CD4 cells around 200. But in case of HIV, there will be a reduction in the number of that CD4 cells, and it will be, we call that patient as AIDS or AIDS patient once the CD4 lowers less than that of 50. 50 cells per cubic mm of blood. So normally it is 200 around that, but in case it is reducing, still at that time also we call the patient as HIV positive only. But when the CD4 goes beyond or lower to the level of 50, then it is the situation when we call that patient as AIDS patient. So these are the three structural gene: the GAG gene, which is responsible for giving the shape of the capsid; the pol gene, which is responsible for the production of viral enzymes, especially reverse transcriptase; and ENV, which help HIV to fuse with the CD4 cells. Then we have the non-structural genes. I put the name. I won't say you to study this. Still, there are TAT, which is TAT and REV, which is important for HIV 1 replication. VPU, which promotes CD4 degradation. VIF, a viral infectivity factor gene, and VPR, it also promotes viral replication. So you see that non-structural genes are mostly helping with the process of replication and also CD4 degradation and the release of progeny viruses. So these non-structural genes, I just mentioned there are 6 and these are the important function. But it doesn't matter even if you forget or you don't study this, doesn't matter. Just for your knowledge, I put it over there. But the other three, the structural genes, the pole, gag, and you need to learn. And what are the primary functions? Then the serotyping of HIV, as we already saw, there is HIV type 1 and 2. HIV 1 is present worldwide, whereas HIV 2 is confined to West Africa. HIV 1 is divided into three distinct groups, M, N, and O, out of which M is the dominant group. And HIV2 comprises of 8 groups, A to H, and group A is the most common form. However, HIV2, as mentioned earlier, it is confined to West Africa. Sources of infection from blood, semen and vaginal fluid, mother to child during pregnancy. So from mother to child, this can happen either transplacentally or immediately during the postpartum or during the process of giving birth to the baby. When there is a mix of blood, then it can happen. So this can happen through contamination with maternal blood or infected amniotic fluid. Also via breast milk and also needles, especially those people who are drug injectors. So if we see the HIV in blood fluids, in blood, the quantity or the infection will be very high. And when you go on, see that value goes on decreasing. In semen, it is still decreasing, vaginal fluid still decreasing, amniotic fluid and saliva is so less. So HIV in body fluids, when we take the concentration, the more it will be in the blood. So blood transfusion becomes the most important reason for HIV transmission. Nevertheless, even saliva could also be a reason. Routes of transmission, blood transfusion, parent to child, sexual intercourse, vaginal, anal, and oral, and also injection. Occupational by needle exposure and some unknown causes also. And why this unknown? Because now the scientists or the physicians know all these mechanisms are there for the transmission of AIDS. And this AIDS control program have been implemented in many of the countries uh, to control AIDS actually. But its number is reducing, but still we don't see a massive change. Like this was first discovered in 1981, as we saw the history. Now it is 2024, so almost 40, 50, 40, yeah, 40 years around, or 4 decades had passed, but still we don't see. And our technology has much developed. So many classes have been given. People know very much about the transmission of HIV, and people are responsible nowadays. They either stick on with a single partner, or they use some protective measures like condoms. all these things. And even for the blood, when the blood is being transfused to another person, screening is done, mother to child, the time when mother or the lady is diagnosed, oh, not diagnosed, when she is found out to be pregnant, at that time itself, all these HIV test is being done. And if the mother is found to be HIV positive, they start the antiretroviral therapy. So, and for the injection, drug abusers also, they have been given much classes. Even the people, almost all the people, if we take a survey only, we will understand. But most of the people, they know how HIV is being transmitted. So when people have a knowledge, and they are actually taking either the preventive treatment or the preventive measures, even needles they take care of. But still, the control measures that we are doing, according to that, the number of the cases should reduce, and it is not happening in case of HIV. And that's a uh, thing that the public health professionals or the physicians or the scientists or the epidemiologists they discovered. So other diseases, when we say that we really don't know what are the mechanisms, or not all the people might be knowing what are the different mechanisms by which the disease is spread. When it comes to AIDS, most of the people would be knowing what or how it is transmitted and how to control it. And most of the people may be sticking on. Not all also. Still, we have doubt that not all people are complying with these preventive measures. So, still, with the number of people who are aware about AIDS and its transmission method, the the decrease that we should see in the incidence or the new cases is not happening in case of AIDS. And that is why the physicians have kept something called as unknown. Is there some transmission mechanism of HIV virus which is not yet known? That might be the reason that even when they are trying to control the disease by all other transmission, still the rate of incidence is not decreasing as much as it should be. Now, HIV pathogenesis. How it is getting attached. So we saw that HIV infects, or it has got a selective affliction towards the CD4 lymphocytes, and also all the immune cells, macrophages, dendritic cells, Langerhans cells, etc. But out of that, mostly it is the CD4 lymphocytes, so CD4 T lymphocytes. With the help of glycoprotein or the GP120, HIV bind to the CD4 molecules. And after binding, it enters into the cell using the GP41. And these things you don't have to remember. So just pathogenesis, remember that HIV has got a special predilection for the CD4 T lymphocytes, and it is with the help of GP120 they will be binding to the CD4 molecule, and with the help of GP41 it will be entering. So initial binding happens with the help of GP120, and then with the help of GP41 it will enter inside the cell. So in case of pathogenesis, the first step will be attachment, and then fusion, where we saw the role of GP120. And then there is penetration and uncoating. Penetration means this virus particle or the HIV virus, it enters into the cell, penetrate, and then it uncoats. It is having an envelope. So that envelope is actually removed, or uncoating is done. Then there is reverse transcription, or the RNA genome, which is present inside the HIV virus. Using the enzyme reverse transcriptase, it will be transcribing into a DNA provirus. And DNA now it will integrate into the human cell genome, because this RNA genome of the HIV virus cannot combine with our DNA, our cell DNA. It is not directly possible. That is why this RNA genome, with the help of that enzyme reverse transcriptase, get converted to DNA provirus. And once it get integrated, and this integration it is helped by the enzyme integrase. And once it is getting integrated, it gets synthesized and matured. Virus progeny will be formed. So there will be processes like integration, replication, assembly, and release. Certain steps are happening. Then the another feature will be latency. So latency, when we say about other microorganism, when we say that particular microorganism is in a latent stage, usually it is in a sleeping mode. It doesn't causes when if you are saying that TB, tuberculosis, the microorganism, Mycobacterium tuberculosis is in a latent stage means it is lying simply in the granuloma that is formed inside the lungs, staying over there. It is not causing any trouble. Only when the situations are favorable, it will become reactive. Otherwise, it is lying like a sleeping mode or in a hibernation. But what makes HIV virus different is its latency. They are able to replicate even in the latent stage and is infectious to the neighboring cells. When we go to the symptomatology, or even now you might be knowing the symptomatology, initially when the HIV infection happens within few days, like maybe around 2 weeks, patient may show the symptoms of some fever, rhinitis, like that constitutional symptoms where we are not exactly able to diagnose. I mean, we can diagnose actually, but when the patient comes, most of the doctors might be thinking if you don't get the origin, like we don't get the history that he's a drug abuser or he's a, person who is having multiple sexual partners or homosexual. If you don't get such a history, a person coming up with fever and some allergic rhinitis, we'll be just taking it as like a viral fever. We are not going, okay, what, the patient comes with a fever, okay, you go to do the HIV test. We are not going to do, but it is possible to diagnose HIV at that stage with the antigens, the HIV antigens. But rarely patients are asked to do that test at that time. So we lose the patients. We don't diagnose. Most of the cases we don't diagnose at that stage. And it's not that all the patients will be developing this fever. Sometimes they don't develop the symptoms. And then these patients will go into a latent stage, and that can vary from 2 to 10 years. And then the patient comes with all the opportunistic infection, all the bacterial, fungal, any infection, because by that time, this latent period when the symptoms are not produced, the organism is not producing any symptoms, it is lying in a latent stage. However, it is showing its pathological activation, that it is replicating even in the latent stage. Unlike other bacteria, viruses, during their latent stage they are completely in a hibernation mode, they are not doing anything pathological. But in case of HIV, they are able to replicate even in this latent stage, and they are continuing that infection, destroying the CD4 cells. And once the CD4 number is reducing, which is actually the T lymphocytes, and T lymphocytes are very important part of the immunity. The T lymphocytes and the B lymphocytes, which is a part of actually the adaptive immunity. So the CD4 cells are reducing means the immunity is reducing. Now, I think immunology we have to study here. I may not take for you people because we have already taken immunity in practice of medicine. And in study of patient and disease also, you're learning immunity, I guess. I remember because I had to take for the last batch. Um, so in that adaptive immunity, it is the lymphocytes, the T lymphocytes and B lymphocytes, which are very important. And T lymphocytes actually help in cell mediated immunity, and B lymphocytes, it releases the hormones, or it is the antibody mediated immunity or humor mediated immunity. But even though we say antibody mediated immunity, it is done by the B lymphocytes. For the activation of these B lymphocytes, they need help. They need help from one of the T cells, and that is called as the T helper cells. And that T helper cell is actually the CD4 cells. So CD4 cells is required for the B cells to do activation and then to produce the antibody. So in case of AIDS, when this CD4 cells or the T helper cells itself is getting destroyed, there won't be much CD4 cells to activate the B cells to produce the antibody. So net effect, what happens is the both the cell mediated immunity and the antibody-mediated immunity. The T lymphocytes and B lymphocytes, the adaptive immunity is totally reducing. And when that happens, any infection is possible in that person. So this is the importance of the latency of HIV virus. And this is a video on HIV cycle. It is of 11 minutes, but I think we will go for a time pass. Not time pass actually, because you need to know what is happening when the HIV virus enters into our human cell. Though I so told all these process, it will uncoat. I mean, it will adhere, it will uncoat, blah 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 things. We'll just see the video. I'm seeing the YouTube page.
Yes.
There are a number of ways whereby HIV can penetrate through blood vessels to reach its target population. It shows two different entities, both HIV and its main target cell, which is the CD4 lymphocyte. The virus has an outer layer, and the outer layer, as you see, contains a number of spikes. These spikes include the major glycoproteins of the virus that are responsible for direct interaction with the cell surface. You can also see the matrix core, which exists in the symmetrical shape of an icosahedron. You can see that structure of HIV is very, very complex. There is a lipid membrane, and from that lipid membrane, you can see that the spikes protrude outward. These include the surface glycoprotein, which is GP120, as well as a transmembrane glycoprotein that is termed GP41. The matrix core, the capsid protein, and the nucleocapsid protein all underlie the outer layer of the virus. And finally, in the inner core, you see that there are two strands of viral RNA, which are associated with three of the enzymes that are essential for virus replication. These are the integrase, the protease, and the reverse transcriptase. This attachment stage clearly indicates how the GP120 is about to bind to its CD4 receptor. In fact, we know that there are other receptors as well that can be involved with HIV entry into target cells. We term these other receptors the co-receptors, and there are actually two of those. One of these is termed CCR5, and the other is termed CXCR4. And these are responsible actually for the entry of viruses into lymphocytes and macrophages respectively. This is the process of co-receptor binding following the interaction of GP120 to the CD4 receptor, which is the major receptor for viral entry and penetration. And this binding event that involves GP120 to CD4 actually changes the shape of the GP120. And now this results in the exposure of a portion of the transmembrane glycoprotein GP41. And so GP41 is important in bringing the HIV virus much closer to the target cell, resulting ultimately in the fusion of the viral envelope together with the fusion of the cell membrane. And this then is essential in viral entry. The transformational change can take place within GP41 as a precursor event in this fusion process. It is essential to point out, therefore, that each of GP120, the CD4 receptor, the CCR5 or CXCR4 receptor, and GP41 are all essential elements in the process of viral entry into target cells. This is the actual fusion process whereby the outer surface of HIV, notably its envelope, can fuse with the CD4 cell membrane. And you can see that one of the consequences of this is the entry of the matrix core of the virus into the host cell cytoplasm. The matrix core can actually become uncoated, and this will result in the disintegration of this core and the release of the capsid inside the cytoplasm together with the genome of the virus. That means the viral RNA, as well as associated enzymes, which can now go to work to initiate the process of viral replication within the host cell. This viral RNA is now exposed in the host cell together with the enzymes, and the two coded viral RNA strands that represent the genetic makeup of the virus can now couple together with the reverse transcriptase enzyme. And in addition to this, the integrase enzyme and the protease enzyme of the virus are also released into the cytoplasm. At the same time, the viral nucleocapsid protein will begin to disintegrate at this stage, and this results in the exposure of naked strands of viral RNA. These naked strands of RNA will now undergo conversion into viral DNA, and this is a process that is mediated by the viral reverse transcriptase enzyme. This is an extremely important step in the viral life cycle because this is the point at which the drugs that block reverse transcription can begin to take effect. It is the formation of a first strand of HIV DNA. And this results then from the reverse transcriptase enzyme being able to move along the viral RNA and read its sequence. And in the process, what we have is the assembly of a copy of viral DNA. As this takes place, the viral RNA actually becomes disintegrated by a different portion of the reverse transcriptase molecule than that which is involved in the copying of the genetic information for viral RNA into DNA. It shows the formation of the second strand of viral DNA. And this means that as the first DNA strand is completed, it now actually serves as a template or basis on which to copy a second strand of viral DNA. And this second strand of viral DNA that is made is actually complementary to the first strand that was made. This is likewise an essential step in viral replication, and this step as well can actually be inhibited by the reverse transcriptase inhibitors. The entry of the viral DNA into the nucleus is a very important process in the viral life cycle, and you can see the double-stranded HIV DNA migrating into the nucleus of the host cell. This is followed by the process which is termed integration. This process is mediated by yet another viral enzyme termed integrase. And what this enzyme does is actually to slice through the DNA of the host cell, permitting the viral DNA to be inserted at a variety of sites in the viral DNA of the host cell. And unfortunately, once this happens, it is fair to say that the cell has been infected for life. This is the transcription of HIV genomic RNA. What happens now is that the DNA, which has been integrated, is now called a provirus and can now be used to generate genomic RNA, which can serve as messenger RNA for the synthesis of viral proteins. In fact, the provirus of the DNA, as represented by viral DNA, may remain dormant over very long periods until the cell becomes activated. This, alas, is one of the most difficult issues that we have to contend with in terms of trying to deal with the HIV infection. Because once a cell has been infected by HIV, it is infected for life. This is the transcription of the viral messenger RNA, which is made from the proviral DNA. And as we said before, the viral messenger RNA is essential for viral protein synthesis. And you can see the construction of a number of different messenger RNA molecules of several different types. It now shows the migration of the viral RNA and of messenger RNA out from the nucleus back into the cytoplasm. And it is in the cytoplasm that we actually have the formation of viral proteins. This is how viral proteins actually get made in view of the fact that ribosomes can move along viral messenger RNA molecules, and the formation of viral proteins will then ensue as a consequence of the juxtaposition of these viral messenger RNA molecules together with the ribosomes. And now, a very important event in the viral life cycle, notably, the viral proteins as they are made are actually first produced as precursor proteins that are not themselves active in any real sense. In other words, these precursor proteins are not actually able to function within the viral life cycle to give rise to finished virus products. What is required, rather, in order to get a virus that will be infectious, in order to reinitiate a new cycle of infection, is that the viral protease enzyme actually cuts these long precursor proteins or polypeptide chains into smaller individual subunits. And this process, in fact, continues even after new virus particles have formed and have budded off from the host cell. The process of viral assembly shows how the viral matrix will form to envelope the various protein segments and two strands of viral RNA. This is the stage at which the viral envelope glycoprotein complex that consists of GP120 and GP41 actually gets inserted into the host cell membrane. This stage reveals the very important process of budding, whereby an immature virus particle will bud out from the host cell membrane. The process of viral protein cleavage by the protease enzyme is a part of viral maturation and will continue even after the budding has actually taken place. The last step in the virus life cycle is the maturation of new virus. The newly mature virus particle is now infectious and contains the various components associated with ability of the virus to initiate a new infection event. The new infection event will, by definition, involve the ability of this newly made virus particle to attach to a new, previously non-infected cell. And of course, this will require that each of the capsid core, the two nucleocapsid proteins, the two strands of viral RNA, two molecules of reverse transcriptase, two integrase molecules, and two protease molecules all be part of this newly assembled virus particle in order that a new cycle of virus replication can be reinitiated.
So I hope you got the process, the pathogenetic process of HIV virus. We'll continue with the PPT. So you saw the important steps over there, how this virus, it is getting attached by the glycoprotein GP120 and then getting inside using GP41 and the enzyme reverse transcriptase by which they will be converting the viral RNA to the provirus or the DNA variety, because then only it can integrate with the DNA of the host cell or the human cell. So for this process, they need the second important enzyme, that is the integrase. And then they start producing the RNA proteins actually, which will be released as the messenger RNA. Then it comes to the cytoplasm. Then as you already learned the process, the transcription, the translation that is happening. And it is the RNA virus protein that is being formed. You see the polypeptides, the action of the protease, then the complete formation of this RNA active virus particle, and then how it is budding off from the cell, the CD4 cell, and then this newly formed, the viral particle will be ready to infect another one. So this is the pathogenetic process of the HIV once it get enter into the human being or the human cell. So this is actually the words in, the whatever process that we now saw in the video and that I told you in words actually. So I'm not going through this once again. You can read it by your own what is happening. all those processes that we saw in the video, it is being repeated over here. Okay, so once the virus particle is released from the host cell, it is ready, I mean, it is ready to be spread the whole body, and that will result in viremia, or the virus is spreading in the blood. The virus can enter the lymphoid tissues, the lymph nodes, spleen, and then it multiplies further. There can be enlargement of the lymph node, massive enlargement, and that condition we can call it as persistent generalized lymphadenopathy or PGL. Then it can infect other immune cells and even the even other cells also. So here there will be profound immunosuppression, and I told you how this immunosuppression is happening because CD4 cells are decreasing, that is the T lymphocytes are decreasing, and we need this CD4 cells or the helper T cells for the activation of the B cells, so that antibody activated immunity can be done, but even that is affected. So there will be profound immune suppression, which results in opportunistic infection and many tumors. Now, the clinical features, we can divide the stages in HIV infection into 4 stages. The first one is acute HIV infection. Then the second stage, asymptomatic or latent infection. Third one is PGL, or the persistent generalized lymphadenopathy. And group 4 is actually the AIDS-related complex. So this is a graph which shows these stages. So the infection is occurring. Initially, within a few months, we can see in some patients, not all, the flu-like symptoms, or there are no symptoms at all. And then this is the activity is reducing. It will go into a latent stage for years and years. And then after years, when the profound immunosuppression has taken place, then the symptoms comes up, the 8 symptoms. So the red color, it actually indicates the activity of the virus, and the blue color, it indicates the activity of the antibody. So initially there is no antibody that is produced against this virus, but when the viral activity reduces, when we say viral activity reduces, you should remember, though it is in latency, it is still continuing its cellular mechanism. It is using its enzyme, it is going on infecting new and new CD4 cells. Only thing, it is not producing any symptoms. That's the only thing. But pathologically, it is doing its own job over there. But during at that time, the antibodies will be produced, so there will be symptom free. However, when the CD4 cells number is considerably reduced, even that antibody production will be getting reduced. And when that happens, when the antibody production is decreasing or the immunosuppression is happening, the symptoms comes out. But during this time, a lot of years would have passed in between. So starting with the HIV disease, the first stage, the virus will be carried to the lymph node and lymphoid tissues like spleen, liver, etc. There will be multiplication in T cells, and the HIV destroys the infected T cells. It can spill over into bloodstream, which results in primary viremia. 50% cases, there will be acute mononucleosis like syndrome or infectious mononucleosis, the disease IMN, which is characterized by low grade fever, malaise, headache, and lymphadenopathy. If any physician is able to get the history about the patient, his drug abuse nature, or whatever the risk sexual behavior he has, whatever that is the, along with that lymphadenopathy, and then the HIV diagnostic test is made. It is very useful, but very rarely it happens so actually. And 50% there will be some acute retroviral syndrome where there is more flu-like symptoms with fever, fatigue, rash, and pharyngitis. That's the characteristic feature over here. There will be significant drop in circulating CD4 T cells. HIV antigenemia or antigens presence will be seen, but antibodies are not there. In the asymptomatic stage, which is clinical latency, that means there are no symptoms, but pathologically it is active. The immune response develops within 1 month. the state of clinical latency, not microbiological or the pathological, which means it is doing its underground activity. So there will be no symptoms. There is a clinical latency, but viral replication is ongoing. There will be CD4 lymphocytopenia, 500 to 1500 cells per millimeter cube. Oh, sorry, it was not 200. This is the normal count, but that will be reducing. Antibody test remains positive, and at this stage, though they don't have any infection, but because this microbiologically they are active, they are undergoing replication, they are infectious. And this is actually a dangerous situation or dangerous phase in case of an AIDS patient. When the AIDS patient doesn't know, not AIDS, sorry, HIV patient doesn't know that he is HIV positive, but because he doesn't have any symptoms, he's not diagnosing it somewhere because no symptoms are there. But at this stage, he's infectious. So the person unknowingly is transmitting infection to many other people. Virus load is also of prognostic value, and this can last for up to 10 years. In people, it may vary from few months to 30 years. And when that latency is broken, that means the immune suppression had happened or the complete CD4 cells have reduced, the disease progress rapidly. There will be CD4 lymphocytopenia, opportunistic infection, persistent generalized lymphadenopathy, AIDS, and death usually occurs within 2 years if left untreated. The third stage, when there is PGL, the lymph nodes, the whole body, it will be getting uh, enlarged actually. So there will be HIV replication in lymph nodes resulting in lymphadenopathy. PGL is defined as a condition where there is enlargement of lymph node more than 1 centimeter size in two or more non-contiguous sites. Non-contiguous means it won't be in a continuous manner, but in different sites there will be lymphadenopathy, and this should persist for more than 3 months. PGL must be distinguished from other causes of lymphadenopathy such as lymphoma. This enlargement of the lymph node can also happen in cases of lymphomas like Hodgkin's lymphoma, non-Hodgkin's lymphoma, which is actually the cancerous condition of the lymph nodes. So we need to differentiate the PGL of the AIDS or HIV from the lymphadenopathy, which is seen in case of lymphoma. There won't be any current illness, but later can progress to ARC or to AIDS. And the last stage, which is the AIDS related complex, which is after to the clinical latency, the CD4 T cell level starts falling. There will be constitutional symptoms, unexplained fever, diarrhea lasting for more than 1 month, weight loss, which is characterized by loss of more than 10% of body weight. And that condition we call it as wasting syndrome. And because of this loss of body weight, more than 10%, we call AIDS also as a slim disease. And this body weight loss can happen due to malnutrition, increased basal metabolic rate, malabsorption, anorexia, and opportunistic infection. There will be fatigue, malaise, night sweat, PGL, splenomegaly, etc. So the HIV wasting syndrome or slim disease, which is characterized by profound weight loss, more than 10%. So the cachectic look the person may develop, chronic diarrhea for more than 1 month, and prolonged unexplained fever for more than 1 month. The opportunistic infection, it can be the oral or esophageal candidiasis, which is the fungal infection most commonly seen. It can be herpes zoster, hairy cell leukoplegia, salmonellosis, and tuberculosis. And tuberculosis is, you should be by now knowing that AIDS and tuberculosis almost go together. Once a patient is diagnosed with HIV, the second important test that is done is TB, whether the person is having TB or not. Or vice versa, when the person is recognized with TB, the second important test or immediately done test will be HIV, because a lot of TB patients may develop HIV, or rather, many HIV patients can develop TB. Because when we learn TB, we will see that TB is something that is seen. I have already discussed that in practice of medicine, that will be seen or infected in many human beings. but most of the human beings have a stronger immunity, which have been developed since years from, or we got genetically from our parents. So most of the people, in them, the TB virus, the TB bacteria, it will be remaining in a inactive or latent stage. And only when the immunosuppression or immunodepression that is happening, some of the other factors which get favors, the TB bacterium will be getting activated and producing the symptoms. So, around 10% if we take, maybe 9 are having the TB bacteria enclosed inside the gonorrhea or the granuloma, we say, in the tuberculosis, and it is lying safe over there. It is not doing anything. Uh, and most of these people won't develop TB also. But in some of them, if the immune suppression is happening, like HIV, they are developing, this activation or the activation of this TB bacteria can happen and TB will be coming out. So whenever a person is diagnosed with HIV or TB, they are done the other disease diagnosis also, because tuberculosis and HIV are so closely associated. Then they may progress to AIDS in few months and to death if the treatment is not taken. Gradually, the patient moves towards the advanced end stage of HIV infection. There is rapid fall in CD4 T cell count, usually less than 200. The virus load will be very high. Lymphoid tissue will be totally destroyed and replaced by fibrous tissue. Opportunistic infection can take place. Development of neoplasia. Many types. Kaposi sarcoma is the one we told. Another one is CNS lymphoma, and development of HIV encephalopathy. Like anything can be possible. There are a lot of opportunistic infection, the protozoal one, toxoplasmosis, cryptosporidiosis, fungal, the most important will be candidiasis, histoplasmosis, pneumocystis carinii, bacterial, mycobacterium avium complex, which actually results in the TB. Then in the viral, we have the CMV or the cytomegalovirus, herpes simplex, varicella zoster, JCV. The Japanese encephalitis, I'm not sure JCV, which virus is that. So the tumors, the Kaposi sarcoma, which is seen in 20% of patients, mostly in homosexuals, its relative incidence is declining. Now it has been associated with human herpes virus or HHV8. So this is the Kaposi sarcoma, which can be seen in the mucosal or even the skin layer. Then some malignant lymphomas can also be seen. In respiratory disease, as tuberculosis, pneumonia can develop, there will be dry cough, dyspnea, fever, neurological AIDS, encephalopathy, dementia. Skin lesions, there can be herpetic lesions, folliculitis, impetigo, seborrheic dermatitis, candidiasis. In GIT manifestations, oral thrush, stomatitis, gingivitis, hairy leukoplakia, symptoms of anorexia, dysphagia, nausea, vomiting, mucosal ulcers, and persistent diarrhea. So this any multiple systems can be affected and the symptoms can be presented. And when all this comes, that's when we call the patient as an AIDS patient. So there is a window period, a window of detection of HIV markers in HIV infection. The window period, it is the time between onset of HIV infection and the appearance of detectable antibodies in serum. So the individual is infected and infectious to others. Antibody test at 4 weeks will detect 95% of infections. Then there is an eclipse phase where there is an interval between HIV infection and the formation of a daughter virion. No diagnostic test is capable to detect the HIV. It will be between 10 to 12 days. The earliest marker will be HIV viral load. The first HIV protein antigen that can be measured is P24 from 1 to 8 weeks. That's what I told in the initially. After to the exposure, the person got the infection. Within weeks, we can diagnose the presence of antigens. But usually, we don't, or physicians casually take it as a viral fever, and mostly we can miss that diagnosis. Then in case of laboratory diagnosis, when we are doing this HIV, we should be careful because there are moral reasons, ethical, legal, and psychosocial factors. It is not like any disease we are getting to know we are HIV positive. The psychology will be getting affected. So three C's are very important while performing the test for HIV. One is consent in written format, confidentiality. If it is a positive test, there should be confidential, and counseling should be provided to motivate the individual and to induce behavioral change. The specific test, we have the screening test, especially ELISA test, and the rapid or simple test. This has been a newly introduced test actually, a rapid or simple test which can be used in a population or a large number of people. So it is one of the important screening tests for AIDS actually. Then we have the most important or the confirmatory test, the Western blot test. This will be the specific test, the P24 antigen, what we do initially. And then it will be the RT-PCR, the reverse transcriptase PCR test, or the HIV RNA test, which is done by the Western blot test. We have other varieties also, nucleic acid sequence based amplification, real-time RT-PCR, etc. Then we can go for non-specific method. The first one will be the CD4 cell count, which is less than 200 millimeter cube. Then CD4 CD8 T cell ratio will be reversed because of the destruction of the CD4. Then WBC, that will be reduced. Lymphocytes obviously reduced because the T cell, the CD4 cell is reducing. There can be hypergamma-globulinemia and thrombocytopenia. So from these cells, these are non-specific actually, which can be seen in other diseases also. But this one, among the non-specific, it will be the CD4 T cell count reduction, which will give us a clue. But other tests can also be done. And AIDS Day for its prevention, you know, it is the 1st December, and we have the red ribbon as a sign for the control or the symbolic support for the AIDS patient, which indicate care and concern, hope, and also the support. You can stop over here.